inside. Over to you, doctor. Thank you.
Thank you for that kind introduction. Without wasting much time, we'll start with the presentation. So in next 40 to 50 minutes, we'll be talking about preterm babies and why is it important to know more about these babies and how to get the best outcomes, not only in terms of decreasing mortality, but also ensuring intact survival. So we'll be talking about the classification of premature babies. We'll be also talking about the various complications which one should anticipate whenever one is admitting or taking care of these preterm babies, because that will help in better management and planning. Then the management of these premature babies begins antenatally. That is, as soon as we know that mother is going to deliver a preterm baby, the management starts right there and then. And then that treatment is continued postnatally at the time of the birth, as well as once these babies are born and they are admitted to the NICUs. So smaller the baby, more is the risk of both mortality as well as mortality. Broadly, we classify them based on the weight and gestation. Any baby who is weighing less than 2.5 kgs is known as low birth weight, and babies who are less than 1 kg, they are known as extremely low birth weight babies, because these are the babies which constitute the very high risk group and they have very high mortality and morbidity. Similarly, any preterm, what is now, we should know what is a preterm baby. So any baby who is born before 9 complete months of gestation or before 37 weeks of gestation is known as premature babies. So again, these preterm babies are classified variously based on the gestation. And any baby who is less than 28 weeks is known as extreme preterm baby, because again, these babies are very vulnerable and they have mortality of almost 40 to 50% and complication rate as high as 60 to 70%. Now, in a country like ours, there are only 3 reasons which constitute up to 70% of neonatal deaths. That is, 3 reasons cause 7 out of 10 deaths for the newborn in our country. And among the topmost is the prematurity. That is, 1/3 of the premature, 1/3 of the babies who die within the first month of life, they die because of the prematurity. So if we take care of this chunk of population, we are going to decrease the deaths by almost 30%. The other 2 common causes include birth asphyxia, that is babies who do not cry at birth, and infection. And again, infection is a very common cause of mortality in country like ours. And preterm babies as such, they are very prone to sepsis because they have got a very premature immune system and they always get admitted. They have lines, tubes, and everything in place, which makes them prone to infection. So if we combine preterm babies or prematurity with infection, this constitutes about 50% of the deaths in the first month of life. That is, if we take care of these 2 things, that is prematurity and infection, we are going to decrease the neonatal mortality, that is the death rate of newborn babies, by almost 50%. Also, the neonatal mortality is the leading cause of under 5 mortality rates. Not only survival is important. Nowadays, we do talk about survival as well as we talk about the neurological outcome, because the new mantra for neonatology or newborn health is that baby should be survived intact with an intact brain, because these babies, even if they somehow survive, there are very high chances that they may land up with abnormal physical growth as well as mental growth. That is, they are high risk to develop cerebral palsy to the tune of 50%. They can have hearing problems, they can have vision problems, they can have attention deficit hyperkinetic disorders, they can have anxiety disorders and other CNS related causes. Now, since the babies are born before the completion of the gestation, their organs are still premature. So almost every organ is at risk of complication. If we start from the head to toe in the brain, because the brain is still developing, these babies have a tendency to go into apnea. That is, they stop breathing for some times, and if they are not taken care of, we do not give them adequate care, they can have arrest also. Similarly, the vessels of the brain, they are very fragile, especially in the first 3 days of life. Any fluctuations in the blood pressure can cause massive bleeding into the brain, which not only causes death, but even if they survive, there is in severe cases of IVH, that is intraventricular hemorrhage, the chances of developing an abnormal brain or abnormal brain growth is to the tune of 70 to 80%. Similarly, the eyes are still developing, and every preterm baby should have eye checkup at 1 month of age. There's also a mission called as 30 Din Roshni Ke. So even if you are discharging these babies, kindly make it sure any baby who is less than 2 kg or less than 34 weeks of gestation, you communicate to the parents and also write in your discharge summary that they have to come for follow-up for retinopathy prematurity, because unless and until you make them understand how important it is to get their babies eye checked, they may lose the follow-up, and retinopathy of prematurity is the most common cause of preventable blindness in newborn. Similarly, their heart is still developing. The heart always pumps blood 24/7 into our body, but because of their heart is still premature, sometimes they have poor blood flow, which makes them prone to shock. They have still an opening which connects the left and right side of the heart, which is known as ductus arteriosus. Because they are born before time, that ductus is sometimes open, and that it can cause severe complications, including pulmonary hemorrhage, shock, feed intolerance. The most common cause for which these babies get admitted is lung issues, that is respiratory issues, because lungs are usually kept open by a thing called a surfactant, which is synthesized towards the end of the 9 months. So any baby who is born prematurely will have deficiency of this substance, which keeps the lung open, and this is known as respiratory distress syndrome. So these babies are prone to RDS. Sometimes they may require 1 to 2 doses of surfactant also. And very premature babies less than 28 weeks will go on to develop will go on to need oxygen for 28 days or more, in which case we label them as bronchopulmonary dysplasia or chronic lung disease. Similarly, their gut is very small. They may not tolerate feeds. They may develop infection leading to NEC. And because of the metabolic prematurity of the lung and other systems of the body, they can have problems like hypoglycemia, hypocalcemia, jaundice, osteopenia prematurity. And since there is hardly any brown fat, these premature babies can have a tendency to go into hypothermia, that is low body temperature, which can itself cause bleeding to the brain, increase risk of infections, and every degree fall in temperature increases the death by almost 20% in these babies. So maintaining a temperature that is the normal body temperature of 36.5 to 37.5 is very important. Even if they survive the turbulent course during the NICU, if they are not taken care during the follow-up, they may have various issues, which we already talked about, like attention deficit, poor scholastic performance, hyperactivity, autistic, autistic disorders, and other psychiatric disorders. And ELBW babies, that is the smaller babies who are less than 1 kg, they can have these problems to the tune of 50 to 60%. Now, we talked about that the management of preterm babies begins once we suspect a mother who is going to deliver prematurely. So right in the antenatal period, we have to be cautious that this mother is going to deliver a premature baby. So we have to think about the baby and we have to start planning for that baby. So the best thing is that any premature delivery should be conducted in a hospital which has a good NICU setup. The NICU which has experience in dealing with these small fragile babies. And remember that uterus is the best transport ambulance for any newborn baby. So once we know that mother is going to be delivering a premature baby, if there is no NICU or there is not an adequate NICU facilities available, the mother should be transported to a center which has a good NICU. This is known as intrauterine transfer. Similarly, if you are knowing that a mother is going to deliver before 34 weeks of gestation, then there is a drug which is easily available, hardly 5 to 10 rupees cost, that is known as steroids. And the best steroid to give to such mothers is dexamethasone, which is easily available in the even in the government small setups, which can be given. There are 4 doses, which should be given 12 hours apart, and the mother can receive this even during the transport. So this antenatal steroid should be given when then and there. They should not wait that we are going to transfer this baby and this mother, and then mother will receive it there. Wherever you are expecting a mother is going to deliver prematurely, less than 34 weeks, kindly give the first dose of steroids, that is dexamethasone. Similarly, for mothers who are less than 32 weeks of gestation, we also have a drug known as magnesium sulfate, which is there to protect the brain, to decrease the risk of cerebral palsy by 30 to 40%. So all mothers who are going to deliver before 32 weeks should receive magnesium sulfate for neuroprotection of the baby. Any mother who has a rupture of the bag should be receiving good antibiotic cover. Similarly, any mother who has a history of UTI, that is urinary tract infection, within the previous 2 weeks of the delivery or any sort of infection should again receive a good cover of antibiotics, because mother can transfer this infection to her baby. Although this may not be life threatening in the mother, but this small infection, if transferred to the mother, if transferred to the baby, can be devastating and can cause life threatening IVH as well as increased risk of death. So, sometimes if it is not possible to transfer the mother as such, then also once the baby is born, you should try to refer this baby as soon as possible to a good setup which has got a level 3 or more NICU. And if we compare in utero versus ex utero, in utero transfer is cost effective because you don't need to arrange anything. You don't need to arrange special ambulance, special incubator for baby. It is less causes less anxiety to the parents, mother, because they know that baby is still there, he is safe inside the mother's womb. Also, if we transfer antenatally, that is in utero, the risk of death is less compared to once the baby is born by almost 20%. And also the chances of brain injury are very less if we transfer the mother before delivering the baby. Now, we talked about the steroids. The best antenatal steroid for our country is dexamethasone. The dose is 6 milligrams. Total 4 doses are given 12 hours apart. And these are given whenever we are expecting a delivery at 34 weeks or lesser gestation. Now, the benefits are various. That is, it decreases death by almost 15%. It decreases the chance of RDS, intraventricular hemorrhage. Also, risk of sepsis, need for ventilation by almost 30 to 40%. So this is a wonder drug which has revolutionized the care of the preterm babies, and no mother who is going to deliver prematurely should be deprived of this drug. And it can be given even in the peripheries as soon as we are expecting a premature delivery. Other drug we talked about is magnesium sulfate, and it is given at gestation of 32 weeks or less. There are hardly any side effects. It decreases the risk of cerebral palsy, motor dysfunction, death of cerebral palsy by almost 20 to 30%. So again, this should be given to all mothers who are going to deliver at 32 weeks or lesser gestation age. Now, once the baby is born, we need to take care of the various things, and the best mnemonic to remember is TABCD. So T is temperature. As we said, that the normal baby temperature is 36.5 to 37.5 degrees Celsius. And because these babies, they are born without much of brown fat and they have a large surface area, they are prone to hypothermia. And hypothermia in itself leads to infection, leads to low glucose level, leads to shock, acidosis. And remember, even one episode of hypoglycemia where a baby throws a fit, there are 50% chances that this baby is going to have abnormal brain development later. So this is something which is totally preventable. Maintaining temperatures, again, a small, simple thing. It doesn't require a high-end equipment. So this should be done. So whenever we are delivering a premature baby, we should ensure that the delivery room or the labor room should have a temperature of 25 to 26 degrees Celsius. There should be no fan, no windows open. There should be no current of air. We should be able to give warm gases, that is warm humidified gases to the baby. If baby requires oxygen, we should, for babies who are even smaller, less than 32 weeks, we should immediately wrap them in a polythene bag, which are readily available, or like cling wrap, which is used for covering the food items, so that they do not have evaporative water loss and heat loss. Or in smaller setups, we can directly, once the baby is born, we can put the baby onto the mother's abdomen, cover both mother and baby, which is known as KMC or skin to skin contact. Again, it is a good, effective method of maintaining baby's temperature. And similarly, once the baby is born, the bathing should be postponed at least by 1 to 2 days. The head, which is constitutes a large surface area of the body, should be immediately covered with a cap, woolen mittens, socks should always be there. And if the baby requires transportation to an ICU or transportation to other center, baby should be either transported in KMC, or best thing is in a warm incubator so that the baby's temperature is maintained. We talked about KMC. It is a very cost-effective method where mother and the baby are kept in skin to skin contact. Not only mother, this can be done even by the other members of the family who are willing to do it. It also promotes, increases breast uh, breast milk, increases breastfeeding rates. It also ensures early discharge and decreases the rate of infection, as well as improves respiratory status, as well as decreases the apnea of prematurity. Now, benefits of skin to skin contacts are both for the mother and the baby. For mother, it decreases anxiety, increases milk production. For baby, it decreases hypothermia, improves sugars, increases physiological stability. Now, inside the delivery room, there should be various equipments available, and one of the most important is delivery room CPAP. As we said, these premature babies, they are prone to respiratory distress syndrome. So these babies should not be given just simple oxygen. Along with the oxygen, they need some pressure to keep the lungs open. And this is done with the help of the CPAP, which provides constant distending pressure so that lungs do not collapse, especially during the expiration. Because during expiration, when we exhale, when we take the when we breathe out, the lungs have a tendency to collapse, especially in the absence of surfactant. So to keep the lungs open both during the inspiration and expiration, we need a constant distending pressure, and this is best provided by the delivery room CPAP. So what you are seeing on the X-ray to the left is a complete white-out lung, and this is a case of RTS, that is respiratory distress syndrome because of surfactant deficiency. And once we give early room CPAP, hardly very few babies will require surfactant. Similarly, if there is a history of PPRO and mother has any infection, then these babies can have even congenital early onset infection also, including pneumonia. And also there we can give delivery room CPAP. Now, delivery room CPAP is given with the help of a T-piece. It's a simple portable device which can be carried in the delivery room, and it can be started as soon as possible. Usually the initial settings, we give a CPAP of 6 to 7 within a 5 to 30%. And then if the babies have persistent retraction, we can increase the pressures. Or if they have saturation less than 90%, we can go up on the FiO2. Now, the indication for surfactant is some babies, apart from the CPAP, they may require surfactant, especially those babies who have moderate to severe RDS. Now, how do we know that the baby is going to have a moderate to severe RDS? So the best, easiest method is any baby who requires CPAP within a FiO2 of more than 30%, even after initial stabilization of 30 minutes to 1 hour. These are the candidates. They should be given a surfactant. And if the babies still do not have low oxygen requirement, or the respiratory distress worsens, or they get intubated, we can repeat a dose after 6 to 12 hours. So the indication for giving first dose is babies having moderate to severe RDS, that is babies on CPAP requiring FiO2 of more than 30%. Now, when to give? The best time to give is initial 2 hours because the lung is still open. So try to give it as soon as possible within first 2 hours of life. And when to give second dose? If the baby's respiratory distress worsens, he has persistent retractions, FiO2 increases, or if he gets intubated, then that is the indication that you should give one more dose. Now, when to give second dose? After 6 to 12 hours of the previous dose, can give the second dose. Usually, babies do not require more than 2 doses, and majority of the babies, they do well with 1 to 2 doses of surfactant. Now, the other important thing which we have common, that is the doctor and the newborn, is the love for the caffeine. So babies who are born prematurely, less than 32 weeks, there is a drug, again a wonder drug, which is called as caffeine. It should be given for babies who require respiratory support and should be given within the first 72 hours of life. Now, what it does is it increases the respiratory drive. There is less chance of apnea, that is baby stopping breathing. It also improves the long-term outcome, that is improves the neurodevelopment outcome, and it also decreases the chances of chronic lung disease. Some important things which we do not do routinely in our NICUs is nutrition, because majority of the time our focus is only on airway breathing. We do not dealt very aggressively on nutrition, but it is very important for any disease, whether it is RDS or any other condition. Nutrition is very important because this is one of the most important pillars of therapy for any disease, whether it is premature or a term baby. So if the baby is not able to take enteral feeds, we should give total parental nutrition, which contains amino acids, lipids, glucose, and adequate electrolytes from day to day 3. And we should start as soon as the baby is stable, at least start some enteral feeds in the form of trophic feeds, which can be around 10 to 20 ml per kg per day. Also, babies who are admitted should receive colostrum within first 1 to 2 hours, because that is very important. That is the first vaccination which the baby gets, because that initial colostrum, which is also known as liquid gold, contains antibodies. It contains anti-infective elements which prevents the babies from infection, which prevents the babies from developing necrotizing enterocolitis. So it should not be missed. So among the milk, the mother's own milk is the best. The second choice is giving donor EBM. And the last, in very rare cases, we should give formula wherever the mother's own milk or donor EBM is not available. For smaller babies, we give feed through orogastric feed. And then as the babies mature, that is around 32 to 34 weeks, we try with Katori Chamach or Pallida feedings. And then around 34 to 36 weeks, we give direct breastfeeding. And remember that ventilation, CPAP, these are not contraindications to feeding. And any baby who is hemodynamically stable can be started on feeding, even if the baby is on ventilator or even on HFO. Other important strategy to prevent necrotizing enterocolitis is probiotics. So all babies who are less than 32 weeks, or if your unit has a high incidence of NEC, you can start probiotics as soon as babies on some amount of feeds, that is around 10 to 20 ml per kg per day, within the first 48 hours of life, and you can continue till discharge or 6 weeks, whichever is earlier. This decreases the chance of NEC by almost 50%. It also reduces the mortality by almost 20%. So every 30 babies, if you give probiotics, you are going to prevent one NEC. And for every 50 babies you give probiotics, you are going to prevent one mortality. Now, we talked about that prematurity and infection, they together constitute 50% of the deaths. So apart from the prematurity, for giving a good outcome to premature babies, the best thing is to prevent infection. If you are able to do this, you will have the best outcomes not only in your state but in the country. So to prevent infection, one should always do meticulous hand wash before doing or before entering the NICU, and from baby to baby, you should always do a good hand rub. Prefer mother's own milk. Always use disposables like circuits, nasal prongs, wherever possible. And also, there should be a good reason to start antibiotics. Do not give them prophylactically, and always try to de-escalate if the cultures are negative or babies is improving. And always try to do a bundle care to prevent unnecessary touching these babies. And always think before you prick these babies whether this investigation is required or not, because every prick, every tube, every line you put in these babies, the odds of infection increases by almost 10 to 20%. So remember, in neonatology, less is more. So the less you do, the good outcomes you are going to have. So it's always important that to remember that prevention is better than cure. You may spend 100 to 1,000 rupees in prevention, but if once the baby gets infection, that same infection can cost the family either the life of the baby or even lakhs of rupees for those high-end antibiotics. So always invest in prevention rather than treating infections. Now, taking care of one other important organ in these babies is skin, because their skin is very fragile and there are various tapes uh, which are put on these babies to fix various tubes, including orogastric, ET tube, lines. So always use the skin-friendly tapes like silicone tape. Always try to maintain good hydration of the skin by giving them a good oil massage with coconut oil. Avoid massaging with mustard oil, olive oil. They are not good for the skin. They also increase the risk of the infection. Or in severe premature babies, you can also use an emollient or barrier creams. And always check, keep on changing their postures. Use the smallest tape possible, and always uh, make the tapes wet before you remove them. This is one of the barrier creams which is available there in the market. So whenever you are putting any tape on the skin of the baby, you should first spray this, which maintains a barrier layer, and then on top of that, you can put the tape. That also helps in easy removal of these tapes when that line or tube is not required. There's other things which are available in the market. You can either use a simple silicone tape or ready-made available things. These are there to prevent the nasal injury whenever you are giving CPAP, HFNC, or NIPPV to these babies, because there is the incidence of nasal injury while giving CPAP or HFNC is almost 30 to 50%. But if you have some barrier over there, this is totally preventable with good nursing care. Other important thing is ensuring that these babies not only survive, they have a healthy brain. For that, you should ensure that these babies get a good sleep. Do not make excessive noise at the bedside. Ensure that the discussions are held away from the cots. Ensure that, like, we do not want to get disturbed while we are sleeping. Similarly, these babies, they require more sleep than us. So during night hours, there should hardly be any disturbance. The light should be dimmed. There should not be any prick or any procedure done during the late night hours unless and until it is an emergency. Ensure that baby is receiving at least 8 to 12 hours of KMC, either by mother or any other family member. Always prefer non-invasive investigations, non-invasive support like CPAP, HFNC, and IPPV compared to invasive investigation and ventilation. Always give some pain relief before doing procedures or before pricking the baby. For example, nesting, swaddling, giving mother's milk. Some of the false notions which are there in the societies that these babies do not feel pain or they feel less pain, which is wrong. In fact, these babies feel more pain than we do. And in fact, if they are given pain during the early life, it causes abnormal brain development later in the later part of the life. So always give a good pain relief and do a pain scoring whenever these babies have any procedure. Now, before discharging these babies, we should ensure that the brain is intact, the baby is healthy. For that, we require for the brain to see for intraventricular hemorrhage and to see for periventricular leukomalacia. We should also have at least one ultrasound before discharge. For eyes, we discussed that any baby who is less than 35 weeks or less than 2 kgs should have first examination of eyes at around 28 weeks. For smaller babies, it can be even at 3 weeks of age. And for good bone health, we should do a phosphorus alkaline phosphatase at around 2 to 3 weeks of age and ensure that they receive good amount of calcium and phosphorus. Phosphorus is a very important thing which is often ignored, both in total parental nutrition as well as the enteral nutrition. Similarly, thyroid function and other metabolic screening should be done. And also, we should do a hearing screening and a red reflex before discharging these babies. In summary, a premature baby is like a seed. So it needs a good soil in the form of good intrauterine environment and good antenatal care. For example, similarly, like the seed or the plant needs a good sunlight. Similarly, these babies need a good thermoregulation. That is, they need a good controlled environment which provides them temperature where they can maintain their body temperature between 36.5 to 37.5. Both hypo as well as hyperthermia can be harmful. They need good water and electrolytes, just like plants do. That is 70 to 80% of their body is water. So these babies should have good fluid management along with the electrolytes. They need good fertilizers in the form of parental nutrition or enteral nutrition. The best thing is giving mother's own milk. And just like we want our plants to be free from pests, similarly, we should ensure that our premature babies or the other babies are free from infection. From that, we need to be obsessed with preventive strategies for infection. We need to use disposables. We need to prefer mother's milk, give KMC, and ensure that these babies have infection-free stay in the NICU. Thank you for patient listening, and I will be happy to take any questions. Hello.
Hello, Piyush ji. Requesting all,
Thank you,
if you
sir.
have any query, unmute your mic and ask your question.
Sure. Go on.
Sir, we can wait for a few minutes. Any closing remark till time, sir?
Hello. Hello, doctor. May I ask one question?
Yes, please.
Sir, my question is this: if the first baby is a preterm baby,
Okay.
so how much the chances are the second baby is also be a preterm baby, or it would be a normal baby? What precaution one couple has to take care?
Majority of the times, the cause for prematurity is non-genetic, but there are some cases or some anecdotal reports where the risk of preterm birth in the family is a risk factor for subsequent preterm birth. The risk is very little, but the only thing you should ensure is that good antenatal care, frequent visits to your OBG, and doing the antenatal scans. Whenever there is any risk factor or any indication of preterm babies, you should ensure that the mother takes adequate rests, gets a good hydration.
Right. Thank you, sir.
Hello.
Yes.
Sir, what is the role of sildenafil?
Uh, Sildenafil, as such, does not have any role in care of preterm baby. Sildenafil is predominantly used for PPH in late preterm or term babies.
Okay, sir. Thank you.
हेलो
Hello.
तो आई थिंक ऑडियंस में किसी और का कोई क्वेश्चन है क्या सर आई थिंक मीटिंग अभी कोई उसका वो नहीं वी कैन एंड दिस